it's a sincere pleasure for me to be part of this conference. They asked me to talk to you about the health services in Quebec, and I'm going to present to you some data based on our research. But first of all, I wanted to talk about access to health services for mental health services in Quebec. And we've developed our concept based on a certain number of studies. The accessibility to service has a lot of different dimensions to it. And so I'm going to illustrate my presentation based on some data. I'm also going to talk to you about two research projects that we did recently. One about emergency services, and also about other mental health services for people with mental disorders. This is based on research that we used with data from the CISMAC database, which was developed in Quebec. It's a very interesting database because it gives us a lot of data about public health. And what's good about CISMAC is it includes all the population of Quebec. It comes from the Quebec Mental Health Services. And so I'm going to be presenting you some data based on this database. And as I said earlier, there are several dimensions in this area which concern accessibility. We'll be talking about financial, geographical, and temporal access to these services. I'll also be talking about a couple other dimensions when we talk about accessibility. So financial accessibility is an important area. And in Quebec, in Canada, we're lucky to have a system that is a public health system, which means that anyone, regardless of their financial situation, has the same access to healthcare. They can have access to the same range of services throughout the country, unlike other countries such as the USA. But also a large portion of our services are private. And a lot of psychologists who work in mental health services work in private agencies. Whether it be psychologists or psychiatrists, they work in private systems, so they must be paid for their services, unlike other areas. And some people can also get healthcare services covered by their employer. But a great deal of the population has to pay for these services themselves. And as we see in the literature, that this healthcare is less available to the general public. Whether it be therapeutic access, such as counseling, and I'll be talking about that later on, how access to these services are a bit more difficult, whether it be for medicine or for counseling. And in many cases, the patients have to pay for these services themselves. And about 85% of these people said that their care was paid for medicine, but not for therapy. It was only about 1 of every 3 people receive financial support for counseling and therapeutic services. Also, when we talk about financial services, we can talk about the financing for the mental health system. In Quebec, it's about 7% of the financing, of the overall financing for healthcare, is for medical healthcare, or mental healthcare. And if we look at France or Great Britain, it's about 15%. And one of our recommendations we've been making for the past few years is to bump up this percentage up to about 12%. When we talk about the concept of accessibility, we also talk about the geographic aspect, which means that wherever you are in Quebec, whether in either of the various cities or around Quebec, you should have access to the same services. And we find that these services are concentrated around universities in the university regions. It's much more easier for variable intensity servicing, psychiatrists. Many of these are concentrated around Montreal. About 60% of these healthcare providers are around Montreal, Quebec, or Sherbrooke. And it's much difficult in more rural areas or in the north, where these services are less widespread. When we look at emergency care, for example, we see that in the rural areas, a lot more people will go to the emergency room to get these type of care than in other areas in the territory. When we talk about accessibility, we also have what we call temporal activity. This means both if we have to get service on the weekends or at night. The only way people can get help then is in emergency services. And when we talk about time as well, we also talk about the waiting lists, which are extremely long in Quebec, whether it be in specialized services or in the first-line services, where there's often several months of waiting is necessary, up to 6 months or even a year. And this can be even for first-line services as far as mental health care. Also, when we talk about accessibility, we also talk about patient segments. We want to have the same range of services, whether we're old or young. We consider the elderly to be people 65 or years older. We know that these populations don't all get the same services, especially for the elderly. We also talk about other areas, which are populations of the communities, where they are Canadians at birth or from immigrants. They don't necessarily get the same services either. They also may have a language barrier, so it might be more difficult for them to get care. Another aspect that I want to talk about was, regardless of the population, we can also talk about certain groups that are more vulnerable than others and might not have access to services. Some do not get the same services, the same access to health care. So this can be substance abusers or people who are itinerant populations. And we also see people who are, once they leave the hospital, who have been in the hospital for a long time. We can talk about the period after they've left the hospital, if they get enough services as well. And we see that once people leave the hospital, they might not get the services they need in Quebec. We've seen only about 1/4 of these people had any medical follow-up within a month after they left the hospital, and only about 1/3 in the period of 90 days. So this is important as well, to talk about the services people get once they leave the hospital, and this is also a vulnerable population. People who have problems with substance abuse also receive much less services as well. And we can use data. We've done major surveys in Canada and Quebec as well to use this data for our services, for our researches. And we see only about 1 out of every 2 people get mental disorder services in these cases. And actually only about 1 of every 5 people who have substance abuse problems get care in this area, compared to 1 out of every 2 in other areas if they have substance abuse problems. And these are people we see a lot in emergency rooms, people who have substance abuse problems. Also, we see people in itinerant populations. We have also statistics in this area, and we know that in these cases, there's an increase by 40% between 2018 and 2022 of this itinerant population. Again, when we look at the data we got from the main big surveys, we know that this is a group that is vulnerable as well, and that there are also a number of substance abusers in this itinerant group as well. And very few of them actually get the services they need. I also need, when we talk about accessibility, we also talked about family care or family practitioners. About 20% of the population in Quebec did not even have family care services, and this problem has gotten worse in the last few years. These groups have less access to family practitioners, especially when we look at people with substance abuse problems. We covered more than 20,000 cases here as part of our research. And And we know that this population also does not get a sufficient number of services. Again, about 40% of this population does not have access to family practitioners. I also wanted to talk about emergency care. It's important to talk about this because emergency care is kind of a barometer for us for how good healthcare services are in the country. Whether it's an outpatient service or regular care, people who don't get enough of this care often go to emergency rooms. This often is an indicator that they don't have access to regular care. And often people go to emergency rooms when they have a crisis, or also people, not necessarily when there's an emergency, but they don't have access to other services. So this is a good barometer for us in this area. We know that about 50% of people use emergency service as their entry, kind of an entryway into medical services for care for mental disorders. And we all know, as many researchers say, that this is not the best way to take care of people who have mental health problems. They do get treatment in emergency care, but it's not the best possible care for these patients. I also wanted to present the results of some of our research that we got from the CISMAC as well. These are statistics which we've got from 2014 and 2015. Initially, we identified a percentage of the population who has mental disorders. And we saw that we can see here how the numbers have reduced the number of these people. And what we also see is what is the effect of this, of the number of, the percentage of the population with mental problems who goes to the emergency room. And we want to compare these statistics with the population who did not have mental health disorders. And we see about almost twice as many people with mental disorders go to the emergency room, unlike the rest of the population, which does not have MDs. So 40% were hospitalized when they were going at least once to the emergency room, whereas if we look at the general population, we see it's much less. It's only about 20%. What's also interesting in this study is we look at the different types of service and what we call the high users of emergency services. It showed that anyone can go to the emergency room after an accident. And that could happen to anyone. But when we talk about high users, we consider that to be someone who's gone at least 4 times in a year to the emergency room. So it's more than just in accident situations. So these again is a sign that these people do not have adequate outpatient service or regular health care. So if we look at 2014 to 2015, we see that there are quite a few people which we call these high users. And this represents more than 50% of the people at the emergency rooms. We also see in this sector a minority of people who actually consume a lot of the resources. Another point that's very interesting is that 20% of the high users who have chronic problems as well, which means they've been using emergencies a lot over the last 4 or 5 years consecutively. We consider these to be chronic users, and we have a great deal of them as well. I also like to talk about a second study which we did very recently, in which we took a look at about the different incidental cases of mental health problems. And we wanted to see how quickly and how appropriately our healthcare services could take these people into account and give them adequate treatment they need. When we talk about incidental, this is a new term we use that we used in our study. Again, we use the CISMAC data when we're looking at a period back for 20 years with this data, from 1997 to 2020, which is the number of people who just had incidents over those last 20 years. And we looked at people who just had maybe one incident in the last 20 years. And what we saw that 1 of every 3 people had an incident, a mental health problem in the last 20 years, which corresponds to what we see from the World Health Organization, which says about 1 out of every 3 people have had an incident in the last 20 years. And what we wanted to see in the study then was try to understand how capable the physicians were of treating these people quickly and adequately, and to see if they had correctly detected the mental disorders that the people had. So there were different indicators here that you can see. We call it prompt follow-up care. This indicator shows us as soon as the problem was detected how well the people were taken care of. Whether it be a general practitioner or a specialist, were they able to give care to the person quickly and adequately? We also looked at another indicator. We looked at how well people were done if they had treatment 3 times in the 3 months after they had been detected. And we decided on 3 months because this is when the crisis period for these people, when they really need urgent help. And another indicator we had was continuous follow-up care. This indicator shows if the person had received at least 5 visits within a year after the incident occurred. So we looked in the population at these different indicators to see how many people had received care and based on these different indicators. And we saw that hardly 1 person out of 3 had gotten the care that they needed based on these indicators. We saw it was a little bit better for continuous follow-up care, though, which kind of corresponds to the studies that we'd seen earlier throughout Quebec. In that area, things are a little bit better. We saw that there was a little bit better in terms of continuous follow-up care. But again, if we look at the overall figures of only 1 out of every 3, we see that there's a big problem in this area. Another thing we want to talk about was that when we looked at all these different figures together, we saw a decrease in the quality of care of the number of care by about 17%, as you see at the bottom here. But we shouldn't, when we talk about this figure you see at the bottom, is that it was hard to follow this because we try to find individual doctors, whether it be psychiatrists or general practitioners, because we've seen over the past 3 years that a lot of these doctors are working now in groups, in clinics and grouped together. So instead of working individually. So it makes it a little bit harder to follow in our databases. So we should keep that in mind when we consider this percentage you see here at the bottom. So again, this is kind of basic. We might say teamwork would have to be taken into account in here. Other results we've seen. We also wanted to see if certain mental disorders were better taken care of than others. So we see depression and bipolar disorders are taken better. People are taking better care of in those problems than we see at the bottom. We also saw that people, which you see in the second line here, people who had chronic physical problems as well were taken care of better. So a much higher percentage of them were taken care of better. Probably because physicians are more aware of these problems and are more comfortable dealing with them. So another interesting thing we see here is that these people who are taken into account with a GMF, which is a group of family practitioners, and we see if they were having problems, mental disorders, they were better taken care of as well. So they get better services if they're in a GMF. We look down here at the bottom, people had more problems, and this is kind of goes back to what I was saying earlier, is younger clients, because younger patients are not taken as full care of, and people outside of Montreal as well don't get as good of services. We also see another statistic here that is interesting. It was for people with this who were experienced their first episode of mental disorder. They were not as well taken care of either. So that's an important element to keep in mind as well if it was their first problem. And with our conclusions, we have certain recommendations in addition to what I said earlier. And this kind of rejoins the literature and what from researchers in this area concerning mental health service. It underlined the importance of consolidating our care for people who have mental disorders. We're talking about better equipping doctors and in GMFs as well. We're trying to give more comprehensive services, that people can get services from the practitioner specialized in the areas that they have troubles. That's very important as well. It's also important to have better access to therapy, what we call counseling. We need increased resources in this area as well. This is very important for people to get counseling. And it's very important in this area that people get support further down the road when they have mental health problems. So we need more financing in this area as well. Also, again, in this category, there are a lot of people who have dependency problems who need help as well. Again, dependence, people who have drug problems take up a large percentage of the resources. It's also important, a recommendation is to better coordinate our services for our healthcare. And I'd like to follow up to say another recommendation, which is important as well, is to better monitor the care that is given and the counseling that is given by doctors. It's very important to have good indicators in order to monitor the treatment that patients are getting, and to make, whether it be clinicians, people in clinics, or in other cases, to make sure that they are giving the right counseling or therapeutic recommendations. So the quality of their work is also very important, to make sure that the diagnoses are correct and that people are getting the proper treatment, the treatment they need. So in order to monitor this, we need good performance indicators to make sure that people are well taken care of and to make sure that our organizations are high performing. Thank you for your time.